Well, hi everybody. Welcome to what is the fifth or sixth webinar in this AN-ACC series by Mirus. I'd like to begin by acknowledging the traditional custodians of the land on which we gather today, to pay my respects to their elders past and present. Where we are today, that is the Gadigal people of the Eora Nation, but I'd also like to acknowledge the elders past and present across Australia, wherever you are today. Extend that respect to all Aboriginal and Torres Strait Islander peoples who may be on this call. Thank you all for taking the time out of your busy days. The industry is at a frenetic pace at the moment. We're feeling it as well. We have hundreds of conversations a month with providers, and everything from an uptick in accreditation visits to COVID still affecting people, workforce shortages. Any number of things going on at the moment, just making us all fairly exhausted. But the thing we're here to talk about today is AN-ACC. So AN-ACC is happening. Legislation's passed the 1st of October. We're going live, all things being well. And so we've been providing a series of webinars for your benefit, trying to provide and shine some light, some information on specific issues that AN-ACC is raising. And today we're talking about, the impact of clinical governance and whether we should, to what extent at least, we should integrate AN-ACC assessments into our clinical governance framework. So we've got three lovely guests with us today to provide a panel and some real information from providers who are sort of tackling this issue right now, not just listening to us. But before we do that, we'll definitely be providing you with some practical information, if we can, about the. Let's bring up the presentation. That might help. Practical information, if we can, about what you can take away from this hour and use straight away. So a little bit of a welcome, some technical information about that you can understand, help understand the problem. We'll hear a little bit from our panel and some first reactions. Then we'll give you some more practical advice that you might be able to use, and then we'll really then deep dive into talking to our panelists about what they're up to in tackling this problem in their organisations at the moment. So. Let's get started. Just wanted to put it into context. So we've been working with over 50 providers on transitions to AN-ACC. It's keeping us very busy. It's about 30,000 beds worth of providers. And, we've really distilled everything that you need to think about before October 1 down to these 7 priorities. There will be a webinar on the 29th of September where we talk about your preparation and where you're up to against these 7 priorities. But to put that in context, what we're talking about today is number 5, which is really understanding how AN-ACC fits into your clinical system and your clinical governance strategy. So what I'd like to do now is I'd like to hand over to Katie, who's the Senior Manager of our clinical area. And she's going to give you some more information, some technical information about what this problem's all about.
Thanks, Andrew. So just to give you a little bit of background, the Department of Health and Aged Care have clearly communicated that the AN-ACC funding model would remove the documentation burden from providers in regards to completing assessments and care plans for the purposes of determining funding outcomes. So the AN-ACC assessments will be completed by an independent workforce, and that consists of registered nurses, physiotherapists, and occupational therapists, all of which have got to have at least 5 years experience caring for older people. Differing from our current and previous funding models, AN-ACC was designed to separate funding assessments from those that we use for developing care and services planning. So that'll allow providers to have more time to focus on truly understanding the residents and really determining what their needs, goals and preferences are. That should allow us to provide better care outcomes for consumers and will also allow us to align more closely with the quality standards. So for over a decade now, it's been a long time in aged care, our approach has really been around completing assessments and care plans that align with funding models. So it's quite prescriptive in the way in which we've approached our assessment and care plans in the development phase. So despite our best efforts, it's quite difficult to merge those funding components with care outcomes and preferences for consumers. So the plan is that moving forward, we'll be able to focus solely on consumer outcome and really get that consumer directed care, which is what we're looking for in aged care. We need to have a little bit of a culture shift in our industry, and that'll take some time to adapt, but it'll mean that we don't have to give prescriptive care measures to consumers, which is really exciting for us. So having the independent assessors undertake the assessments that are directly related to AN-ACC means that every provider and anyone who's undertaking those assessments will now be empowered to really drive that change and change our approach in how we deliver services across aged care. On the next slide, we're going to have a look at what those clinical impacts are. So over the past several months, I'm sure probably a lot of you have kept up to date on the sector performance reports. The one thing that stands out quite frequently is that standard 2.3A, which is assessment and planning that informs safe and effective care services, is often ranked in the top 10 non-compliance standards. So when we think about that and how if we're going to integrate the AN-ACC assessment tools into our clinical framework, it's really important that we consider the potential risks related to inconsistency in information in particular. Historically, we've seen, or when we've been doing auditing, we've seen that different assessments often have different care measures associated to them. So if we incorporate another suite of assessments into our clinical framework, something we really need to consider is, have we got the right system and process in place to mitigate that risk? For example, if you have your mobility assessment or physiotherapy assessment, which is a comprehensive tool in your care management system, and then you're also using or implementing the DEMI, it's really important that those two outcomes align. If they don't, obviously, then we're leaving ourselves open for potential risk and non-compliance. So despite having systems and processes in place, it's frequently found that there's inconsistency within that area of our assessment and planning. Under the quality standards, we need to understand not only our consumers' functional capabilities, but also, truly understand their needs, goals, and preferences so that we can determine so that we can help them get their best outcome or their preferred goal. The AN-ACC assessment tools are quite simple tools, I'm sure you've all seen. So they don't really bring in that component of person-centered care. They're really about understanding the functional capabilities of a person and don't take into consideration someone's needs, goals, and preferences, which is what we require under the quality standards. So each provider will probably have a different approach to how they determine what assessments, or if they're going to incorporate assessments, if they are, which ones they'll incorporate, or will they incorporate the entire suite of AN-ACC assessments into their clinical framework. So something to consider moving forward, just identifying those risks. On the next slide, we're going to have a look at capturing the importance of information in our current clinical systems. So one thing that we've noticed as we've been doing a lot of case conferencing with our clients is that the analysis of the shadow assessment data often we've found that there's inconsistencies in the way in which the AN-ACC assessors have identified care need versus how the provider or the organisation has determined care need, and in particular around cognition. So when we work with our residents so closely, we understand them from a holistic point of view, not just a snapshot in time. And when our AN-ACC assessors are coming on site, they're limited to a time frame in which they can assess consumers. So it's very, very important that we are able to proactively provide them information that is current to the resident needs, and it's freely available to them. So keeping your cognitive assessments, whether that be if you're continuing to use the PAS or a mini mental or any other accredited tool. It's really important that they're kept up to date. A lot of the times where we found that variance in the cognitive function is where assessments are more than 12 months old when the AN-ACC assessors come in to review the residents. So that's showing often a variance in that score outcome. So the other thing we also should consider is compounding factors. Highlights or the most commonly triggered things in compounding factors that we've been able to determine so far is around daily injections, behaviours, weight loss and falls. So making sure that your systems are showing that in the care plans and any information that you're sharing with the providers. Also keeping your diagnosis list up to date within your care management system. And variances in mobility capability. So again, something that we pick up quite often is, a mobility assessment may say something along the lines of a resident requiring physical assistance. And then perhaps the toileting assessment might say that they're independent in use of toilet. So making sure that everything's nice and consistent will really help support you if you're requesting reassessments under AN-ACC. And then also consider making sure that your source material, so material from external health providers such as geriatricians, doctors, hospital discharge summaries, if they're in support of any changes for reassessment, it's really important that you incorporate that into your clinical information that you're able to provide to the assessors. Some other feedback that we've had around that process and supporting the AN-ACC process is where assessors have come on site and our staff are almost frightened to talk to them. Probably comes from a stigma from a long line of different funding models where we didn't want to share information. But in the new world, it's really important that we are transparent and open and are able to effectively communicate the current needs of our consumers. So next, maybe we'll have a look at what we should be thinking about as an industry. So what are some of the benefits that you might achieve by integrating the AN-ACC assessments into your clinical framework? If you haven't thought about that already, it's something to be thinking about. You may choose to incorporate none, you may choose to incorporate some, or you may want to adapt all of the AN-ACC assessments into your clinical framework. Just remember that you need to consider what impacts that will have on your workforce and the timing of that integration if you choose to do it. The other thing that you might want to consider when you're developing those systems is what will be the trigger to identify requests for AN-ACC reassessments. And of course, have you updated your policies and procedures to reflect any changes that you'd like to embed into your systems. So on that note, I might pass back over to Andrew.
Yeah, thanks for that, Katie. I think that was a great introduction into what we're talking about here. AN-ACC is very different to ACFI. ACFI is very prescriptive. AN-ACC is basically a mathematical decision tree, an algorithm that's designed to give you a classification outcome and an amount of money, which you then need to determine through your care planning how you're going to implement that implement that care for your residents. So it's quite different. And I guess there's a lot of work involved. I'll talk about in a bit later. There's a lot of work involved in making those decisions. And so we've been working, like I said, with a number of organizations, over 50 organizations, and there's enormous variation in the way that those organizations are approaching this problem, from some organizations that are panicking a little bit about systems upgrades required to get the AN-ACC modules into their system, and the work effort required to redo all their care plans and redo all of their assessments, and the time frame and the resourcing requirements and the constraints that they have. And I guess one of our key messages is, slow that thought process down a little bit and consider the fact that AN-ACC assessments are not chosen to be clinically applied in that way, that the way that you're doing your care planning and your clinical approach at the moment, it doesn't necessarily need to change. and you need to think about, how you're going to approach that, and really come up with a plan and a strategy, I guess, is a key message. But before we go any further, what I'd love to do is firstly introduce you to our panel. Natasha's from Kalira communities in South Australia. Nicola is from Penn Villages in the central coast of New South Wales, and Kate is from Anglicare in southern Queensland. So we're covering a few states here. Thank you so much, ladies, for being on our panel. It really makes an enormous difference to the webinar to have some real world experience, and not just us talking. So what I wanted to do before we go too much further is just get that first reaction from you. I love to hear about thinking back to the first time you thought about that, these new AN-ACC assessments might be coming in and you might have to change your clinical governance or change your approach to clinical governance. What was your first reaction with it? We'll go into what you're doing about it now a little bit later, but what was your first reaction? We might start with you, Natasha.
Thanks, Andrew. My first reaction was, yes, we absolutely have to be doing everything that the AN-ACC assessors will be doing. That was the initial reaction, that we all have to become experts at those tools. And yeah, I guess that was before we knew that we weren't going to understand and be able to totally administer the tool ourselves.
Mm. And did it cause a bit of concern? Were you worried about it? What were those initial questions?
Yeah, I can't say we were worried about it. What our focus really has been so far has been getting our care minutes correct, making sure we do a review of our rosters, what's in and out of care minutes and things like that. So this has been, we're really just starting to turn our minds to this now. And I guess, I've come a long way from that initial reaction, and I'll talk to you a bit about that later. My initial thought was, we're going to have to train everyone in each of these tools, and invest a lot of time in that. And I'm not so sure about that now, but that's the way we need to go.
Yeah. Okay. Thank you, Nicola.
I think it was, here we go again, probably, having been in the industry since RCS and then having ACFI, I think that we probably feel fairly equipped to change, because we're going through changes all the time, let's face it. But the fact that the information has come out fairly slowly, and it really wasn't until 1 or 2 months ago that we knew that it was actually going to be implemented at an industry level in October. So we sort of, because the information to an extent has been drip fed, and we haven't really known where we've been, it's made it more difficult to really align sort of long-lasting changes into the organisation. And even now, we're still not sure where that's going to evolve to. So I think initially it was very much, here we go again, and we can do this. And then that thought kind of keeps evolving, really.
Yeah, I think really early on, I mean, we've been looking at this since May, but the point about drip-fed information is fair enough, I think. And I think the information is going to start moving rapidly, but very interesting to see the legislation get passed. And even the department themselves, in the conversations we've had with them, said, a lot of things will start moving quickly now. Because a lot of it was tied up with getting that legislation across the line, which of course they wanted to do many months ago, and with elections and other delays, it didn't quite pan out that way. So we'll wait and see. Kate, what about you? What was your initial reaction and the reaction of Anglicare Southern Queensland?
I think Nicola just took the words right out of my mouth. I was just going to say, here we go again. That was probably from myself and obviously people, once again, who've been in the industry since RCS days, and a little bit of apprehension, I suppose, the timing of the change with everything that's going on in our industry. And I think from what I was hearing from some of our facilities was about it will mean more work. So I really made sure for myself in my role to be able to learn a bit more, and it was hard because there's not things coming out at rapid pace. So I think when I've been able to really put my head into learning more about AN-ACC and being able to advocate why is it coming in, and be able to reassure some of my colleagues, I think that's helped, along with, I suppose, the next step that we're going to talk about, what we're up to now. But I think that was probably a lot of anxiety out there, just because we are still facing with COVID and all this is a big change for us. But as I said, I think that was where my focus was trying to ease some of that anxiety from our facilities, and to try and get them back to why we're changing to AN-ACC and some of the benefits that they're proposing that AN-ACC will bring as well.
Yeah, and I think everyone's automatic reaction is just to assume it's sort of similar to ACFI, but it's, structurally in this particular way that we're talking about today, it's really very, very different. That separation of clinical governance and care planning from funding is really quite a big change. It doesn't seem so big, but it really is, as well as that, from my point of view, at least, the external process. Early on when they talked about the external process, everyone's first reaction was great. All of this, 7 or 8 hours of assessment writing and documentation in ACFI, isn't that going to be great? We don't have to do that anymore. But I think as time's gone on, most certainly the organisations we're working with are realising that you really need to have a fairly firm grip on the assessment process and on really understanding the assessment process yourself and being your own assessor to really make sure that you know what that outcome is going to be. And then in terms of this conversation, really understand what kind of information will be required to support. Because I think, and I'll go on to talk about this a little bit now. I mean, really, what are the practical aspects to consider? What can you take away from this conversation practically? I mean, really what you're trying to balance is these two things. You minimize the impact on the quality of your care planning and the extra care plan and system work that's not required. Systems changes you don't have to do, and care planning changes you don't have to do, and training that you don't have to do, at least not initially. So what is that versus, how do you actually bring supporting information, AN-ACC supporting information into your system in a way that ACFI didn't need, so that it supports that external assessment process? And I think, those 2 points on the side there, I mean, one of the game changers that's about to be announced probably in the webinar from the department straight after this is that they're planning on lifting, if you haven't heard this already, they're planning on lifting all of those reclassification constraints. So the hospitalisation and the changes in mobility and the 6 month, 12 month, depending on the classification, they're planning on lifting those so that you can reclassify anytime you feel like the classification doesn't match the care requirements of that resident, and without penalty. So there is a facility in the legislation to charge for reclassifications, but the Nick and the department have told us numerous times that there's no intention of applying that, unless we get into those silly situations where people are asking for reclassifications all the time without reason. So, having a open reclassify anytime process means that really identifying reclassifications as quickly, as early as possible, as soon as possible, not acting on them, because obviously acting on a reclassification, unlike ACFI, acting on a reclassification in AN-ACC has a care minute requirement impact. And even though that's not mandatory in the first 12 months, I think the industry needs to figure out how to manage that on a weekly, monthly basis throughout that 12 months, so we're ready for when it is mandatory, because obviously there's serious consequences for getting it wrong after October 2023. And the second thing, whoops. And the second thing is really that structural limitation of the external process. I mean, the way it's designed to have somebody come in for a fairly short period of time and not really knowing the resident means that there really is a knowledge gap that needs to be filled by the information that's available in your system. And Katie talked a little bit about that how do we get that information in the system to make sure that the outcomes that we're looking for from the external assessment process are realised. And so getting this balance is really the key to the problem. Not doing any work we don't have to right now, not doing any work that actually makes the quality of our care planning and the consumer directed care worse by using potentially assessments or information that's not as the same quality as what we're using already, versus making sure that the right information's in our systems that are available to the external assessors to make sure that they get the right result in the time frame that they have. So what this kind of looks like from a practical point of view is really the it's not just about the system. The other thing to consider, the other practical aspect to consider is really building this pipeline, this trigger event. So what is the trigger event that is going to, in your system, that is going to help you identify when a reclassification is possible? So this slide shows kind of crudely the three really important things that are going on in your organization around admissions and the changes of those classifications and the change of the classifications on your cohort class case mix, and the reclassifications that will now be available all the time under AN-ACC with removing those constraints, and the impact that that may or may not have on your rosters. And this is a dynamic problem because what you want to do with your rosters varies quite a lot across the 50 providers that we're working with. There's a lot of variation in the facilities at the facility level about whether that particular facility has stable rosters or needs to increase its funding to increase its care minute requirement to match its rosters, or decrease its funding to decrease its care minute requirement to match its rosters, or maintain some stability in its funding to maintain some stability in its care minutes to match its rosters. So these are all the variables that come. But what we're talking about in the context of today is, how do you actually have enough information in your clinical system, or enough information coming out of your clinical processes, that not only are you providing that information for the external assessors, but you're somehow identifying those triggers and when you can potentially reclassify a resident, if that's the advantage that you want to take. And here are some ideas that you can think about. Obviously, there's some well-documented ways that things that we record already. We know when people are hospitalized, we know when people have falls, we record that already. Other reportable events, these are things that we can easily be triggered by and say, okay, that may affect AN-ACC, let's have a look at that. For stakeholders, for generate the resident of the day process, a regular review of our residents. We're doing that all the time. The stock take approach, where somehow we're using existing processes or existing rituals to add an AN-ACC reclassification or classification review into that process to create trigger events. Or the other way is some other way of continuously assessing in a safe way. Now, using your clinical system to do that is a big question mark. I know some of the big clinical system providers are, adding AN-ACC modules in, and that's great. That's a great step forward. But one of the questions we really need to ask ourselves is, the clinical system is the only system that the external assessor is going to come in and look at. So what do we want to show in our clinical system? Do we want to show the accurate information around our care planning? Do we want to show the supporting information that we know is clean and clear and supports the case we're looking for? So where do we put all this continuous assessment? Where do we put all this data where we want to play? We want to capture lots of assessment data. We don't want it clogging up our clinical system. We're only doing it for the purposes of AN-ACC. So it's very kind of AN-ACC specific superficial information. Where do we capture that? Where can we build scenarios? Where can we play? So this is a real systems gap that's opening up for AN-ACC. And if anybody needs to talk to us about that further, it's a systems gap that we're trying to fill with our Mirus Metrics platform. But before we get into that, if you want to look at how the AN-ACC assessments work, if you haven't downloaded the AN-ACC Calculator app already, it's free. It's available on the app stores, both Android and Apple, and it really will give you a good opportunity to go through the AN-ACC assessments if you haven't already, and really understand how those AN-ACC assessments are working a lot better. But also, when it's applied in a practical sense in your facilities, could potentially be used as a tool to continuously assess residents and try to look for those trigger events and communicate that through your organization. So a very simple and practical approach to how you might solve that problem in the future. So now back to the panel. Now we get to the really interesting bit of the webinar, I think, which is really hearing from them about where they've come from, where they're up to now, and where they think they might be going next. And so to do this, we might go backwards this time and start with you, Kate.
Thank you. Look, it's been a bit of an interesting journey for us, and I think probably where I started was just taking a bit of a step back and understanding, obviously, AN-ACC, and obviously, as I was saying before, about why we're doing it, and comparing it to some of the things that I see that we very dictated by ACFE, and obviously it created a lot of extra documentation for our nurses. So I really wanted to make sure that I looked at those components of why we were changing the funding tool for AN-ACC, and I think Katie said before about the documentation burden. So I really wanted to make sure how I can actually look at AN-ACC into the current systems that we do have, rather than making it additional to what we're doing, but obviously keeping a bit of a clinical governance, obviously the revenue and the business model as well. But for my nurses and obviously the facilities on the ground, I wanted to be how it actually complements what we're doing. And I think that's what I see a great thing about AN-ACC is it's getting back to that if we do good assessments and good care planning, then the funding comes. So I really wanted to make sure that that was where my focus was, is really looking at our resident journey and how I can actually embed some of the AN-ACC requirements into that resident journey from pre-admission to obviously throughout our stay in our facilities as well. We have been looking at those processes, so it's been a really good opportunity of really focusing on those key components of a resident's journey, as I said, from our pre-admission and how we actually record the AN-ACC there to help with our decision making as well, and obviously the care planning. But then we're really looking at how we can then get our nurses to really embed AN-ACC requirements into their job. We took a lot of the feedback that we got from our shadow assessments for our AN-ACC too, so where the assessors, and I think there was a comment in there as well, that we really need to make sure that our documentation is giving the assessors the information that they need to make that assessment. So that's where our focus has been, and some feedback that was around our documentation. Our progress notes didn't actually give the evidence that those assessors need to be able to fill out the AN-ACC assessments. So that's where our team has been really focused on, is our care plan reviews that I'm sure everybody has, and how we can really make that more robust and include some of the AN-ACC languages in there as well. So I haven't really looked at using those AN-ACC assessments yet. I really want to just try and get our current system right to be able to get that information right to our to the assessors. We are also looking at sort of how we can actually make it, I think Katie said before, the currency of our assessments too. So not just waiting for our care plan reviews. So what is our actual current system now that we are doing reassessments as a resident's condition changes, rather than waiting for our care plan reviews, or when it used to be when their ACFE was due. So we're really having to re-educate some of our nurses around that. As a person's condition changes, that's when we do our reassessment, and then that's when we would do our clinical governance to look at that reclassification of our AN-ACC as well. And obviously we were looking at those roles that we've got in our clinical governance structure as well. So all our roles of our RNs and how that would be incorporated into their roles as well, to be able to support that really good consumer focus outcomes. And as I said, I think if we can get our documentation right, then the AN-ACC is going to come as a result of that as well. So that's where we're really at the moment. I really want to try and get that clinical practice documentation right. And then we're actually then looking at how we can do those AN-ACC assessments, what that role is for our organisation. That's probably the next step. I just want to really get the embed some of those things in our current system that we're doing.
Thanks, Kate. Great. And how are the staff responding to that?
Look, as I said to you before, they were a bit anxious when the change happened, but I think once we've actually started, we've done a couple of workshops with our staff, and we've actually, with our, especially our clinical staff, really getting them back to focusing on what they're currently doing. And I can see the change in them. I can see that they're actually coming along this journey as well, because they can see the benefits of not having to do assessments for the sake of a funding, that we're doing now assessments because that's what the resident needs. And obviously that's why we're here. So I think the change in their attitude has been good. Can I just say that it is a bit of a change process with them, because obviously we've been so focused on assessments for the sake of funding, that there has been a little bit of a journey with some people, but as I'm sure we will all experience with any change, it's just trying to give them a bit more support where needed with changing some of their routines of how we do assessments.
All right, great. Thanks, Kate. What about you, Nicola?
Um, Listening to what Kate was saying, reflecting on that, and what we've spoken about already, I see the role of what is currently our ACFI manager and are moving to our AN-ACC manager as being really critical. And as an industry, I think we really looked at with this funding changing coming in, what would it mean to us as organisations in regards to the roles? And Kate, you mentioned that as well. But when we look at what our AN-ACC manager will do, we're really fortunate. We've got a fantastic ACFI manager, and I know she's worked really closely with yourself, Andrew, and your team to really look at what AN-ACC means to us as an organisation. I see their role as very much being around governance moving forward, particularly as we implement this new funding model, and we're not really sure quite what it's going to mean for us, and particularly when we start having questions around external assessments and whether or not they're really aligned with what our assessments have been. So I see her role as being really critical as we move forward. And I just want to underscore, I think, when we're talking about what we've done here, as how important I think that role is to an organisation. So to an extent with ACFI, they were a gatekeeper, but when we're talking about recognising deterioration in residents and wanting to reapply for a re-evaluation, I think their role is going to be far more critical than we probably ever thought before. Mm. So how we've approached it at Peninsula, we've in our care software system, we've integrated the assessments. And I think it's difficult because we're using one tool really for a regulatory compliance, for continuity of care, and trying to really reinforce person-centred care. And then we're also using it for a funding tool, and they don't always quite mesh together. So it's trying to find that balance. At the moment, what we've done is integrated all of the assessments into our general practice. So our staff have taken on that well and have been doing that on admission. Our physio has been using the more the functional type assessments around mobility, and that's been working for us. However, when we went from RCS, we've had the same clinical system when we went from RCS to ACFI. Our focus changed hugely from being progress notes based from RCS to being monitoring chart based, and that could be depending on our system. So it's a change within our documentation, our culture that underpins how we document for us, because we're now going back to having a more of a focus on progress notes. So particularly for staff who have worked here for ACFI, it's a change in their training and how they document. And we've decided we still need the same monitoring chart. So for us, we do feel that there is going to be more documentation probably than what we've required in the past. Our ACFI manager at the moment, the staff are continuing to do the AN-ACC assessments. However, she's looking at whether or not she's going to do them themselves, because what do they add clinically to the picture at some times. So, but we're very conscious about wanting to make sure that our assessment and care planning, progress notes, monitoring is aligned with a funding tool for that consistency. We've put together guides for our staff, exactly what's expected at every stage around documentation, to try and really make sure we have a process that's embedded. But like with any change, it takes time to embed that.
And Nicola, how are you communicating that with your staff? Have they been, are they happy to accept the change so far, or have you come across any challenges?
I think it's a real period of flux at the moment. We're probably 2 months into implementing the new documentation system, or the change in the documentation. Our ACFI manager has set up daily sort of cheat sheets around what you document each day to really try and support them with that process change, so that we're giving them as much as support as we can to implement it. But like with anything, it's not something that happens overnight. They just don't change what they're doing. And we're in the midst of COVID in New South Wales. We've been struggling with staff being off, as every organisation has been. So there's challenges that are impacting how smoothly things change. And I think we need to be cognizant of that, because you can't just say, tomorrow you're starting to do this. We've got to really look at a big picture and how we can roll things out.
Yeah, there's a couple of good points there. I mean, you know, like I said earlier, the AN-ACC is going to happen on October 1, whether you like it or you're ready for it or not. So I think this is it's not about getting ready for October 1 in all cases. Sometimes it's going to be a transition that goes on for a number of months after that, a year even. So that's why we really focus on that big 7. But I think you do really raise a really interesting point there, Nicola, for me, which is this idea of centralisation versus decentralisation. So what is the role of some sort of central roles, maybe the new AN-ACC team, maybe the quality team, versus what is the expectations on the clinical teams that are on the floor and what's going to change for them. So I think that's an interesting dimension to the question as well. Natasha, what about you?
We haven't raced ahead and incorporated any of the AN-ACC assessments into our systems as yet. Apart from the DEMI, our physios are using that. What I see is this is a really exciting opportunity to do a complete rethink of all of our clinical documentation. Having been in the sector, I think it was Cam and Sam when I started, that was RCI, then RCS, and then ACFI. As a sector, we have had this reactionary response to a lot of change where we've just added layer upon layer upon layer upon layer to our systems, and that's across our whole organisation, not just our clinical systems. So I see this as a really exciting opportunity where we're not having to focus on the language so much about how you word, you know, particularly around behaviours and things like that. We can actually really focus on good clinical assessment, person-centred goals, really good care planning processes. What I was seeking was a way to be able to, because at the moment we're really only doing our care plan reviews every 6 months, to come up with a way of scanning, you know, identifying when residents have changed, to be able to use a tool that can, you know, guide you through to say, okay, what's changed and what do we need to do a deeper dive into to reassess them. And I recently attended a meeting with the Adelaide Primary Health Network, and they're working with the University of Wollongong and University of Western Australia on some of the palliative care tools. So the PACOP program, which is a similar suite of tools that's what's being used in the acute sector and community palliative care services, and they've developed a suite of tools for residential aged care facilities, which coincidentally cover off on 3 of the AN-ACC tools in there as well. So my preference is to look at probably a suite of those assessments, because they do look very good. We're very early in thinking, and our software provider haven't incorporated that into their system yet, but when I met with them last week, they definitely are looking at the PACOP tools. So that will be my preference, is to, which really isn't to do with funding. This is about really good clinical assessment. It replaces things like the SPIC tool because it's a lot more relevant to the older people. And so I think there's, you know, a whole range of clinical outcomes that we can use or achieve by using some of those tools in our system, rather than focusing just on the funding outcomes. Having said that, we all know that the funding is really important. So for me, it's about identifying when there's change, make sure we've got great clinical documentation, and then figuring out how we're going to manage that referral process going forward. Like Nicola, I think, we won't be removing our ACFI role. That will be more focused on a clinical systems coordinator role, making sure our clinical systems are really effective. And if we're getting, I really believe if we can get that correct, then at the outcome of that, we should then be able to decide, has there been a change in classification that then will lead to a referral. So first and foremost is about good clinical outcomes, good clinical systems. The other piece of work that we're doing is, like Nicola said, I think that getting better documentation into our system is really important. And we're looking at our IT system and rolling out a mobile device which is a bolt-on to our existing clinical system that enables our carers to be able to, do very quick voice to text progress noting, very good charting. It just looks terrific, and I really believe that sort of system will not only improve time at the bedside, because we've not got people hovering around nursing stations trying to remember at the end of their shift. They can document as they go, but also get better documentation because it's happening real time. So there's a few bigger systems that we're looking at as well.
Wow, some of that sounds great, but you brought up a point there that I thought was interesting as well, and others mentioned it, which is the role of allied health. So obviously there's a big change going on with allied health in the industry at the moment, with the changes to the 4B pain management approach between ACFI and AN-ACC. And for certainly across the organisations we're working with, everybody's reviewing pain management and therefore allied health across the spectrum of clinical requirements, which is great. Another great outcome from the change is just the necessity to review some of the things that we're doing that we maybe haven't looked at for a long time. Is one of the great outcomes of change. It's painful in some ways, but it could be great for our residents. But the allied health, did you want to just expand on that a little bit, how you're thinking about using allied health in that process? I have heard, and Nicola, I know this is true at Penn Village as well, that trying to use the allied health a little bit more to do things like the DEMIs and other things, the more functional ones, as you mentioned, is an opportunity.
Yeah, absolutely. So as we said, we are using the DEMI now. Also looking at how we manage pain. So we're doing two things at the moment. One is consulting with residents, so having some focus groups with our residents about, how effective is your pain being managed? What is it that's important to you? Starting to float some different ideas to get their feedback. So that's first and foremost, what is it that our consumers are wanting us to deliver? We have an excellent service. We have external contractors for our physiotherapy, but they are a very much embedded part of our team, and they will continue to be an important part of the services that we deliver at Kalara. But having a bit more flexibility in how we manage pain. So we're working with them to have a pathway, really focusing on new admission and getting people, I guess, that folks having that restorative approach on admission, focusing on, maximising their functionality, any pain that might need some short-term interventions. So having that initial restorative approach and then moving through to a more of a maintenance program. So that's where our thinking is with managing our allied health. I do think there will be a reduction in the hours that we'll be needing, and that is quite variable across each of our 3 homes at this time. But we've decided that we'll take a fairly slow and considered change process to moving across to that, just given how much our residents and the feedback we're getting from our residents is how much they are valuing the existing services that we're delivering. So yeah, we don't want to throw the baby out with the bathwater, so to speak, when we do this change. We do want to make sure we do that slow consideration, considered approach, and in consultation with our people.
Yeah, because I have heard that and this is only anecdotal feedback, and it's certainly not written down in any rules, but any documentation that we've seen. But I have heard some feedback from an assessor that via a provider that if the assessor comes in and does a DEMI, and there's a DEMI on record that's been done by a physio or an RN that's different, that they will take that into consideration. So that sort of highlights potentially the benefit of having your RNs or allied health involved in some of the assessments. Obviously the assessors need to come in and do the assessments from first principles themselves. That's the way the algorithm works. That's the way their iPads work. They've got to go through the algorithm to get the classification result. But it's good to know that that information, if it's available in the system, could be looked at from time to time, and certainly trying to address that that shortfall where, you know, a moment in time view of a resident, as we all know, does not necessarily represent their care needs over time, over a 1 week or 2 week period. So yeah, interesting use. And Nicola or Kate, have you had any thoughts about using allied health more or less in other clinical areas that might support sort of documentation for the external assessment process?
We're really taking this opportunity, similar to what Natasha is saying, to really review the services that we provide, and the mandatory minutes gives us an opportunity, but also with the 4B claims changing. We're looking the same thing with our residents, whether or not what we're currently doing is meeting their needs. Obviously, if what we're doing is, we're not going to change that, because I think personally that's going to be, from a regulatory point of view, an issue, just because of the funding tools change. So, but we're looking at moving much more to, I think, a wellness model than we ever have before, and looking at the role our physios play, their contractors as well, but very embedded, such as Natasha's, and really looking at what an occupational therapist could bring to our resident care, and really looking at opportunities to embed that wellness model with a sort of a bit of a shift of allocation of our funding, what we can do internally to really support our residents' independence as they live with us. So we're really excited about the opportunity. Actually, it's a really positive thing for us.
Yeah, I agree. Kate, anything to add to that?
Yeah, look, very, very similar to what Nicola just said. I think we're just taking the opportunity to really review what we're doing. Once again, not being, I suppose, our pain management around funding, you know, getting back to what good pain management wellness is all about. We've got an opportunity to look at a more probably proactive falls prevention program maybe in there as well. So I think that's probably where I'm finding a lot more excitement out in our facilities, is to be able to maybe look at what we've been currently doing, but opportunities to be innovative with what maybe, you know, best practice evidence says around this area as well. So very much like what Nicola said too about the occupational therapy, we haven't had that a lot in aged care moving forward. So I think this is now a great opportunity to sort of look at those other allied health that could obviously benefit our residents as well. So and yeah, same as Nicola, I think that's the excitement I see in some of our staff being able to come up with some ideas that they're seeing that are benefiting our residents, and some of the ideas that they're coming up. So we're trying to get them on that journey as well. So they're seeing, obviously, our residents and our families, but our staff are seeing the positive changes of this as well. So they've come, you know, getting us some ideas about how we can move forward with that.
And as you're transitioning your residents between programs or different services, have you come across any residents who are adamant that they continue their 4B treatment, for example?
For us, we're just at the sort of beginning, I suppose, with that. So we have been looking at our lower hanging fruit at the moment, the people that are refusing, that haven't had it for a while. We've actually noticed when we've started talking to some of our residents that the service is being delivered by a physio, but it mightn't be in a way of a massage. It might be in a way of that they're actually going for a walk. So that's sort of the next group of people that we're looking at. So what we thought might have been happening when we're going and talking to residents, it's very different to the service that's being delivered. There hasn't been many for us yet that have, because they've been on these 4Bs for quite a long period of time. Some don't realise why they were on it in the first place, and hence why they transitioned to a walking program. So I think we're just probably finding at the moment with the type of people, the residents that we're seeing, we're not getting that just yet though. But I'm sure it will be there, but we've also got to make sure that we, probably plan for that, which we're doing in part of that scoping as well.
Well, we might just pause there just momentarily and have a quick flick over to the Q&A and see if there's anything that's popping up in the chat. So Taryn has been monitoring our chat, or Katie, I think you've been looking in the chat and answering some questions as well. Anything interesting popped up there that we haven't sort of covered yet?
We do have a question asking if we can get some feedback from the panelists on which care management system they're using, and in particular, if it's a standout from an AN-ACC point of view.
I thought actually the panelists did a fantastic job of avoiding naming their the clinical systems, not to create any bias or recommendations or anything like that. But yeah, if you guys are happy to speak about your system, then that's fine.
We use ManAd Plus. We've been using it well over 10 years now. I really like the system myself. It embeds quality, funding, care documentation. We've been happy with it. And it has a mobile app too.
Mm.
Yeah, we're using iCare, and we've been using that for, I think it's about 14 years here at Kalara. Again, we're not wedded to any particular system, but when we did a review beginning of 2020, we realised we weren't maximising use of our clinical system. So given there's been a pandemic in between, when we commenced that process, and now we're still trying to make sure that we review and move away from paper-based and have it all in our clinical system. So I don't know that this year clinical systems got all the answers. Sometimes it's how well you're using it, and that you're not creating systems outside systems as well. So hence why we want to really use this opportunity to build on that work, and make sure we've got our processes and systems correctly. And then it may be that we do move to another system. I don't think that's our plans at this time, but I don't think that that's going to be the key driver is who we're using. And to be honest, we've seen what's in the pipeline with iCare with Mirus, and it's looking quite good. But yeah, it's not definitely, I don't think there's any one clinical system out there that's going to be a one-stop shop that's going to have all of your answers. I know we need to use Zoho Analytics to do our data mining and things like that. And so, yeah, no matter what you go with, you'll probably need to have some workarounds to meet your organisation's needs.
And we use Autumn Care, and I probably agree with Natasha. I think no matter what care system maybe you use, it's just as good as the user. And I always say, go back to a saying with my staff, it's, good data in is good data out. So no matter what system you use, you've got to get that good data going in. So that's what, as Natasha just said, that's what we're focusing on, is really making sure that we've got it right no matter what system that we would be using. That would be probably still our focus.
Yeah, excellent. I think in fairness to the system providers, there's not been a lot of information that they need. They've had to go on. So a couple of people, LeeCare and Telstra Health, definitely in our experience across all of the people we've been working with, have sort of led the way and ManAd put some information out. Autumn Care have been working on it. That's great, but they are flying a little bit blind. No one really knows exactly how it's all going to work yet. So one of the dangerous things to do is to be building new systems around unknown requirements. So I think like several of us have talked about, there's going to be a very rapid learning curve in the first 12 months when it's all very real and we know where the limitations really are and what we're really struggling with. And it's a really exciting time for vendors, system providers. Obviously, we provide a number of systems ourselves. A very exciting time to be trying to respond to the market need, to the industry's needs in that first 12 months to see if we can really support the industry with better technology. Anything else there, Katie, at all?
There's a couple of questions around progress note entries. So in particular, flags around doing exception progress note writing versus continued progress note writing. Yeah. So a question there directed at Nicola, just asking for your point of view on that.
We're certainly encouraging our staff, as we always have, to do any exception reporting. Our care system, if you do an incident form or anything like that, you can link it to your progress note. So we absolutely encourage our staff to make sure that everything is documented, that's exception in there. I don't know about how everybody else feels, but if I'm looking for information on a resident, I tend to always go to the progress notes as my first snapshot. we're also, because we're trying to make sure that the information in our assessments and our care planning is reiterated in progress notes, potentially for funding, that's where we kind of have the guide that will say, this week you're talking about hydration and nutrition, this day you're doing so and so, and it's just divided up. So staff will do, say, 3 notes per shift. So there's to try and minimise the burden and make sure that it's, I guess, shared, and also we get perspective of all 3 shifts, because I think that's important, that the residents do change across shifts, and it's really important to pick that up as well. So we the system supports that. I hope that answered your question.
Does anybody else want to add anything to that, Natasha? Okay.
I think just, yeah, probably for us, the same with what Nicola said. We have taken some feedback from the assessors about our documentation in progress notes. So, yeah, and that was the most common feedback that we did get around, yeah, what Nicola was just saying, complementing with what we're actually doing as well. So, and that was some 4 of our sites that didn't have PCWs doing documentation in progress notes, compared to some of the sites that had PCWs doing documentation in progress notes. So that's been a big change for us. We've had to really go to the sites that haven't had that in part of their culture, and really support the PCWs with being able to document progress notes and what to write in that term. So that's been part of our journey as well, based on the feedback that we've got with our assessment so far.
Yeah,
Right. So, sorry, go ahead.
Sorry, we haven't done a work on documentation with our carers for a very long time. So this will form part of our rollout when we do these new bolt-on at the bedside type reporting. That will also be what sorts of things are we writing, and I think we need to do a complete rethink so that they're not reporting for reporting's sake, because that clutters up systems too if it's not meaningful. So as an organisation, we need to define exactly what is meaningful information and what is it that we want people to, and that's a conversation that we've yet to really have.
Yeah, that's a good point. It's just data's just data. It's got to be insightful. So thank you again, Natasha, Nicola, and Kate for joining us. Katie for providing your insights. That's all we've got time for. We do have a department webinar starting now, which hopefully will give us more exciting news about what's to come. I do want to thank you all so much for joining us, and just want to remind everybody that the next webinar on the 29th of September is really just a couple of days before we go live. And we're going to go back over those 7 focus areas that you know, you really should be on top of before 1st of October. And I know it's sort of late to be talking about it then, but if anybody needs more information on that, definitely reach out to Miris. We're doing a lot of work across the industry, helping people transition, and we look forward to seeing you again. Please put any comments in the chat, any feedback for the sessions, what would make them more useful, or any ideas on what future topics might need to be to help the industry. That's why we're here. But just one more time, thank you very much to our panelists for taking the time, and for all of you for coming out and spending an hour with us. And hopefully we've shed some light on this topic area and given you something to take away and think about and do. So have a great day wherever you are.